السلام عليكم ورحمة الله وبركاته. إن شاء الله نكمل اليوم الكترولايت امبالانس. كنا بدأنا في هايبرناتريميا، إن شاء الله نكمل اليوم هايبرناتريميا. أتمنى إن شاء الله استفادة للجميع. نبدأ اليوم بكيس. This case will be discussed at the end of the lecture. 70-year-old male patient, a case of chronic obstructive pulmonary disease was transferred from another hospital with fever, increased breathlessness for 5 days, altered sensorium since 1 day. He also had an episode of seizure 1 day. He was being managed on lines of acute exacerbation of COPD with cor pulmonale with pneumonia. He received antibiotics and diuretic therapy in previous hospital. On evaluation, his laboratory values showed hemoglobin 13 gram per deciliter, serum sodium 164 milliequivalent per liter, serum potassium 3 milliequivalent per liter, serum urea 146 milligram per deciliter, serum creatinine of 1 milligram per deciliter, and his blood sugar is 400 milligram per deciliter. So let's start. Plasma osmolality and tonicity. We discussed this issue or this point before. I will give a rapid hint again on it. Again, if there is any high solid concentration in the blood, this indicates high hyperosmolarity, but not hypertonicity. Hypertonicity occurred only if the solutes or substance is not readily permeable through the cell membrane, the sodium. However, if the substance like urea or ethanol if it's readily permeable through the cell membrane, so it will not cause hypertonicity. It will not cause osmotic activity. Only will cause hyperosmolarity. And if there is low solutes in the blood, this will cause hypoosmolarity. Okay. And in case of hyperosmolarity, the water will be shifted from the cells out, and the cell will be shrinked. And in the case of hypoosmolarity or hypertonicity or with hypotonicity, the cell will be edematous. Cell edema will occur because water will be shifted inside the cells. Again, we discussed before calculated plasma osmolarity. It is 1 divided 2.8 plus glucose divided 18 plus 2 sodium. And we mentioned that calculated plasma osmolarity is about 290. And because urea is not an effective osmol, has no tonic effect or has no osmotic activity, so it will be removed from effective plasma osmolarity calculation. And we mentioned that sodium is account for 98% of effective osmotic activity. And we mentioned also osmolar gap, which is the difference between measured osmolarity and calculated effective osmolarity. If this osmolar gap more than 10, it may indicate drug toxicity or alcoholism or other substance, as we mentioned before. So let's go directly to hypernatremia. Normal serum sodium, as we mentioned, 135 to 145. Hypernatremia is serum sodium more than 145. And hypernatremia is reported in 25% of ICU patients. What's clinical feature of hypernatremia? The clinical feature of hypernatremia, again, as hypernatremia is more related to acute hypernatremia rather than chronic. Acute hypernatremia will cause hypertonic plasma, which draw water from the cells and causing shrinkage of brain cells and hypernatremic encephalopathy. What is hypernatremic encephalopathy? It is osmotic demyelination because of cell shrinkage. And this clinically range from agitation, lethargy, up to coma and seizures. And unfortunately, this hypertonic encephalopathy has a poor prognostic sign and carry about 50% of mortality. In chronic hypernatremia, some patients is asymptomatic or has less symptoms because again of cerebral adaptive mechanisms. طبعا كنا اتكلمنا على الهايبوناتريميا with cerebral adaptive mechanisms. chronic hypernatremia كنا قلنا ان بيحصل ان السيلز بتفقد osmoles. The cells will lose some osmoles to cause intracellular hypotonicity to equalize with the blood hypotonicity. So the brain edema will be less. Here again, in chronic hypernatremia, after brain cell shrinkage, the brain adaptive mechanism will start, and generation of osmotically active substance within the cell membrane will be formed. يعني البرين will generate osmotically active substance called idiogenic osmoles. These idiogenic osmoles will increase the intracellular tonicity, so will restore the cell volume and cell shrinkage will decrease. Okay, so in chronic hypernatremia, the symptoms will be less, but the problem is the rapid correction of hypernatremia. If rapid correction of hypernatremia occurred in chronic hypernatremia, it will be has very bad consequences. Why? If we rapidly replace free water deficit in chronic hypernatremia, this will cause rapid shift from hypertonic site to hypotonic site, and this rapid shift will cause cerebral edema. Why? Because still there is osmotic active substance inside the cells, which is formed during adaptation, cellular adaptation, اللي هي الايديوجينيك osmoles. The idiogenic osmoles will draw water. When the blood osmolality will drop, these osmotic osmoles will draw water from the blood and causing cerebral edema. So the limit or the target of decreasing sodium during treatment is about 0.5 milliequivalent per liter per hour, or of average of 10 milliequivalent per 24 hours. Let's go directly to hypernatremia algorithm. Hypernatremia is very easy to be diagnosed, and the cause of hypernatremia should be catched easily if we follow this algorithm. By doing urine osmolarity and urine sodium, only these two tests will help you to catch the diagnosis. So urine osmolarity, if the urine osmolarity less than 700 to 800, or more, maybe the urine osmolarity maybe less than 700 milliosmol per liter, or more than 700 milliosmol per liter. If more than 700 milliosmol per liter, assess volume status, and the most important, to do urine sodium. If urine sodium more than 25, so this indicating that there is sodium gain with water gain, but the sodium gain is more than water gain. And usually this is because of iatrogenic effect, and we are giving a patient some hypertonic fluid, and this hypertonic fluid causing hypernatremia, like giving the patient hypertonic saline infusion or sodium bicarb infusion. Some cases in female patients, psychiatric female, sometimes they are receiving excessive ingestion of salt. If this situation not found, if we are not giving any hypertonic fluid, so assess potassium and DVBG, because there is maybe hypokalemia or metabolic alkalosis with hypertension, and this may indicate hyperaldosteronism and Cushing syndrome. Okay, if urine sodium less than 25, so this means there's extrarenal hypotonic fluid loss. I mean there's extrarenal loss of water more than sodium, and the result will be sodium more than water in the blood. So the sodium in relation of water in the blood will be higher, so hypernatremia will occur. So what is the cause of extrarenal hypotonic fluid loss? Any GIT loss, like watery diarrhea from osmotic medications or drugs, viral gastroenteritis, vomiting, or loss from insensible sites, or what's called insensible water loss. Insensible water loss meaning that there is water loss from sites other than GIT or renal, mainly skin and respiratory system. And if there is loss of water from skin and respiratory system, this is called insensible water loss, because this cannot be calculated in the fluid chart, so it is insensible. So any skin loss, like in case of sepsis with fever, heat-related illness like heat stroke, burns, or patient with tachypnea, or patient in mechanical ventilation, will cause insensible water loss from respiratory system. And lastly, if the patient is receiving before any osmotic diuretics or loop diuretics and now he is not receiving, so this may cause hyponatremia with urine sodium less than 25. The most important thing, the extrarenal or even renal hypotonic fluid loss should associate with failure to thrive or impaired thirst to cause hyponatremia. Why? Because if there is hypotonic fluid loss, normally the physiological response in any healthy person, the person will drink more water, so he will compensate for this hypotonic fluid loss and hypernatremia will not occur. However, in patients with debilitating or multiple comorbidities or chronic illness or advanced age, all of these cases, the patient cannot drink well and there is what's called failure to thrive, so hypernatremia will occur. So extrarenal hypotonic fluid loss should be associated with failure to thrive to cause hypernatremia. On the other hand, if the urine osmolarity is less than 700, again assess volume status and urine osmolarity. Usually in the if the urine osmolarity is less than 700, the patient will be hypovolemic or euvolemic, because patient will be polyuric. Urine output will be higher. Okay, so if urine osmolarity is less than 700 but more than 300, this indicates renal hypotonic fluid loss, like osmotic diuresis from hyperglycemia, which cause glucosuria, mannitol infusion, sometimes in stress dose steroids, high urea from high protein feeding, and also in case of post or polyuric phase of acute tubular necrosis. Urea causing osmotic diuresis. When ATN resolved, this cause polyuria. So the recovery phase of azotemia will cause polyosmotic diuresis or polyuria. Also loop diuretics, as we mentioned before, furosemide mainly, because furosemide is causing diuresis with water excess more than sodium, so hypotonic fluid loss will occur. And post-operative polyuria, post-renal obstructive polyuria. Okay, and again, these patients should have failure to thrive to develop hypernatremia. Okay, if not of these causes is not found, so you should think about partial DI. Okay, if the urine osmolarity less than 200, this will indicate complete DI. How to confirm the diagnosis of DI? The diagnosis of DI is done by water deprivation tests. We will not give the patient any water or IV fluids for few hours, usually 4 to 6 hours, and the result should if we do water deprivation for few hours, the urine osmolarity shouldn't increase more than 30 milliosmol per liter if there is DI. Failure of increase of urine osmolarity more than 30 milliosmol per liter. For example, if patient has severe polyuria, more than 3 liter per 24 hour, and you check urine osmolarity, you find it 150, so you are suspecting complete DI. Confirm this by water deprivation test for a few hours. If the urine osmolarity is not increased more than 30, if it was 150 become 160 only, so this confirming complete DI. But actually water deprivation test should be carefully monitored, because patient may develop hypovolemia rapidly. So you should monitor the patient carefully. If there is any signs of hypovolemia, stop water deprivation test because it will be harmful. Then, after confirmation of complete DI, to differentiate between central DI and nephrogenic DI. First of all, what is central DI and what is nephrogenic DI? Okay, central DI, it is caused by failure of ADH secretion from posterior hypothalamus, so it is central cause. While the nephrogenic DI is caused by failure of the response of the receptors in the kidney to ADH. So it's end receptor problem. This nephrogenic DI. So if we do desmopressin test, if we give the patient desmopressin, if the patient has ADH deficiency in central DI, the test will be positive. While if patient has good ADH secretion and the problem in the receptor, so the desmopressin test will be negative. Okay, what is meant by negative and positive? If we give desmopressin 10 microgram intranasally or 5 units IV, the urine osmolality should increase at least 50% to indicate positive test. Okay, and if you give the patient desmopressin, usually we are giving intranasally 10 microgram, the urine osmolality should increase by 50%. And if, for example, if it was 100, the urine osmolality, it should be at least more than 150, 160. So it is more than 50% of urine osmolality. If it is positive, so it is indicating central DI rather than nephrogenic DI. اوكي، وات الباثوجينيسيس؟ طبعا احنا اتكلمنا عن الباثوجينيسيس في كل الحالات، يعني it is a repetition. الباثوجينيسيس may be sodium gain more than water gain in case of hypertonic fluid intake, or maybe extrarenal or renal hypotonic fluid loss with failure to thrive, or maybe failure or disorder of renal water conservation. يعني there is free water loss in case of DI. The kidney cannot conserve water، ما تقدرش تحتفظ بالمية، قلنا بسبب اما ال ADH centrally not secreted or the ADH not causing its action due to receptor problem in nephrogenic DI. Let's go to DI. What is diabetes insipidus? There is criteria of diabetes insipidus. I think we mentioned all. The patient usually euvolemic, sometimes hypovolemic, sodium hypernatremic 145, and there is hypotonic urine in face of hypertonic plasma. It's very important. Hypotonic urine, patient is giving very large amount of urine output with hypotonic urine. The urine osmolarity will be less than 200 in complete forms. With hypertonic plasma, more than 290. And if you check urine specific gravity, it will be less than 1005. And to confirm this, by water deprivation test, as we mentioned, it will be negative. So what's central DI? Central DI is failure of ADH release from the posterior pituitary gland, and this will cause failure of renal water conservation. What is the common cause? Any cause of brain insult will cause central diabetes insipidus, like head trauma, neurosurgery, granulomatous disease, any infectious disease, neoplasm, vascular disease like stroke or hemorrhage. All of this can cause central DI. Nephrogenic DI, it is impaired end organ responsiveness to ADH. The defect in renal concentrating ability is less severe in nephrogenic DI than in central DI. يعني nephrogenic DI is less severe than central DI. What is the common cause of nephrogenic DI? It may be inherited, drug-induced, electrolyte imbalance, inherited drug-induced electrolyte imbalance, and some intrinsic renal disease. طب the most important is drugs and electrolyte disorder. Drugs that cause nephrogenic DI, lithium is very important, aminoglycosides and amphotericin C, radioactive dyes, dopamine, dimeclocycline. يبقى 2A aminoglycosides amphotericin, 3D dyes radioactive dyes, dopamine, dimeclocycline, and L lithium. Again, aminoglycosides, amphotericin, radioactive dye, dopamine, dimeclocycline, and lithium. All these medications can cause nephrogenic DI. And to electrolyte imbalance, is very important to know that they cause nephrogenic DI, hypercalcemia, and hypokalemia. So hypokalemia is a result of DI and it aggravates nephrogenic DI. Okay? Again, what is the diagnostic approach? Is a repetition of what we call, but it's a systematic approach. Okay, first of all, you should assess onset of hypernatremia and take history of hypernatremia before and review lab of the patient if it's available. Assess severity of hypernatremia and assess neurological symptoms and examination to find if this patient has symptomatic hypernatremia or asymptomatic. And take history from the patient. Is there extrarenal loss? Is there any diarrhea, vomiting? Is patient is febrile? Has any signs of sepsis? Is he taking any the diuretics before? His patient is old age, has debilitating illness, any renal history of polyuria, and this indicating acute kidney injury or post-obstructive polyuria, recovery from azotemia or post-obstructive polyuria. And is there any neurological symptoms like head trauma or surgery indicating central DI? Is there any drug history, which is very, very important? Is this patient receiving hypertonic fluid like hypertonic saline, sodium bicarb? Is patient receiving mannitol, stress dose of steroid? Is this patient receiving loop diuretics? Is this patient receiving medications that causing nephrogenic DI, which is mentioned just now? Then examine the patient, the volume status as we mentioned before, and again do neurological examination for central DI, and is there any signs of Cushing syndrome or Cones, which is commonly associated with hypokalemic hypertension. And then do labs, serum osmolality, usually for sure it will be high, urine osmolality, which is very important, urine sodium, which is very important also, blood glucose, which is so important, and KFT in case of polyuric acute kidney injury, post-obstructive polyuria, nephrogenic DI, VBG and electrolytes to catch Cushing, Cones I mean hyperaldosteronism or nephrogenic DI. Then lastly, the treatment of hypernatremia, including Society for Endocrinology 2021 guidelines. So we'll go step by step for treatment of hypernatremia. First of all, as hyponatremia, we should correct hypernatremia for hyperglycemia. Again, to remember, because it's very important here in hypernatremia, average every 100 increase above the first 100 of glucose will decrease the sodium by about 2 milliequivalent per liter. And for example, if the patient has RBS or blood sugar 400 and sodium about 160, so there is 300 more above the first 100. So there is 6 milliequivalent per liter which should be added to the sodium. And sodium will be 166. again every 100 of glucose, of increase of glucose above the first 100 will decrease the sodium by 2 milliequivalent per liter. Okay, so this decrease you should add, and because it is dilution, the glucose causing dilution effect, local dilution effect on sodium, so you should add this dilutional effect and correct the sodium. So first correct hypernatremia for the serum sodium, for the serum glucose, then stop any medication that can induce or contribute to hypernatremia, and we mentioned all medication before. Then if the patient is hypovolemic with hemodynamic instability, forget hypernatremia and give resuscitation with normal saline, 0.9 saline. Type, how to replace water deficit to correct hypernatremia? First, you should calculate water deficit. How to calculate water deficit? There is an equation. Water deficit is equal to total body water multiplied by corrected sodium divided 140 minus 1. Okay, what is total body water? Total body water is in adult male about 60% of body weight. 60% I mean of body weight here. And in adult female and old patients, it's about 50% of body weight. Yani average patient, if patient is 35 years old, adult male, and his weight is 70 kilogram, so total body water will be 35, 50% of his weight. If patient is old or woman, okay, sorry, in adult male it's about 60%. Yani low 70, it will be about 30. It will be about 40. Total body water 40 mil. 40, yes, if the 40 liter, I mean. So if the patient has, if the patient is female or old patient, okay, and his weight or her weight about 70, so it is 50% of his weight, so it's about 35 liter total body water. So calculate the total body water, multiply it in correct sodium, divide 140 minus 1. This will give you the water deficit, what you need. Then after calculating water deficit, calculate the volume of replacement according to type of IV fluid. What I mean, if you are using D5 water, so give the calculated water deficit volume. For example, if the water deficit you calculated 7 liter, so the patient needs this 7 liter by D5 water. If you are giving hypotonic fluids like half normal saline, or half normal saline is 0.45% saline, or quarter saline and 0.2 saline, or linger lactate, this need equation to know how much fluid you should give for this patient. The volume of sodium containing hypotonic fluid equal to water deficit multiplied 140 divided sodium in fluid per liter. يعني لازم تبقى عارف how much the sodium in every liter of this fluid. And I give you an example. Sodium in hypotonic fluid, for example, in half normal saline, it is 77 millimole per liter. In quarter saline, it is 33 millimole per liter, and in ringer lactate, it is 130 millimole per liter. Okay? يبقى first calculate water deficit from this equation. After calculating water deficit, if you will correct with D5 water, give the patient will need equal volume of water deficit. If the water deficit is 7 liter, the patient will need 7 liter D5 water. If you are using half normal saline, so it need equation which is water deficit multiplied 140 على الصوديوم اللي في الفلويد. لو الصوديوم في الفلويد for example half normal saline 77, us use 77 140 over 77. This will give you the amount of fluid you need. طيب sodium containing fluid is the first choice. يعني you should firstly think أو give sodium containing fluid like quarter saline or half normal saline to correct total body sodium, because the patient, as I told you before, the patient has hypotonic fluid loss. So the patient already has sodium loss. The total body sodium will decrease, but the relation between sodium and water, the sodium is more than water, but the total body sodium is decreased. There is total body sodium deficit because of loss extrarenally or renally. So half normal saline or quarter saline is the first choice to use to correct hypernatremia. D5 water should be used in DI because DI has free water loss, not hypotonic fluid loss. DI usually has free water loss. You should replace with also free water, which is found in D5 water. And also in refractory case of hypernatremia, you should use D5 water. Hyperglycemia should be good controlled. طبعا if you're using D5 water, there is risk of hyperglycemia. طبعا if there is hyperglycemia, this will aggravate hypernatremia by osmotic diuresis due to glucosuria. Okay, what is the rate of correction? انت خلاص حسبت amount of fluid you will give. How to give, or what is the rate of correction? For hypernatremia with severe symptoms like altered mental status or seizure, serum sodium should be corrected at least 5 millimole per liter in the first hour or until symptoms improve, and is limited to 10 millimole per liter per the first 24 hours. And this is the new guidelines actually. Little bit aggressive actually, but this is the new guidelines. If the patient has severe symptoms like altered mental status, you should correct the sodium, or seizures, you should correct the sodium in the first hour 5 millimole, and in the rest of 24 hours, the other 5 you should increase the rest. In the rest of 24 hours, you should increase the rest of 5 millimole, and the total shouldn't exceed 10. But in the first hour, you can increase about 5 millimole per liter per first hour to alleviate symptoms, to control symptoms like seizure. For asymptomatic or mild hypernatremia, serum sodium correction shouldn't exceed 0.5 millimole per liter per hour. Also limited to 10 millimole per liter in the 24 hours, particularly in chronic hypernatremia to avoid cerebral edema. خلاص يبقى we shouldn't decrease sodium more than 10 millimole per 24 hours to avoid cerebral edema. And you should monitor sodium for sure 4 to 6 hours. And then treat the cause. In hypovolemia, you should give saline, 0.9% saline, used in if the patient is hemodynamically stable. And you should give saline if the patient is hemodynamically stable. And then replace water. يعني ده الترتيب بتاع الهايبوفوليميا. لو الهايبوفوليميا hemodynamically stable, خلاص start by replacing water deficit. If the patient is hemodynamically unstable, resuscitate the patient first and stabilize hemodynamics by normal saline, then replace the water deficit, and then treat the cause. In the eye, first replace water deficit as we mentioned, then treat the cause. In central DI, usually we are giving desmopressin, which is vasopressin analog or ADH analog. And the dose usually 5 microgram intranasally once daily, up to 20 microgram BID, and we are increasing the dose gradually according to the response, 5 by 5, or 1 mic subcutaneously once daily or BID, or 1 mic IV once daily or BID if the patient is not responding to subcutaneous route. And the serum sodium should be monitored carefully during vasopressin therapy, اللي هو desmopressin therapy, because the risk of rapid hypernatremia correction or even water intoxication and hyponatremia. يعني الفازوبريسين may cause even hyponatremia، يعني يحصل العكس، يحصل hyponatremia أو يحصل rapid hypernatremia correction, which is not good, as we told, may cause cerebral edema. Okay, النفروجينيك دي اي طبعا correct electrolytes and stop offending medications. Hypervolemia in patient with normal renal function, usually sodium and water are excreted rapidly and sodium will be corrected spontaneously. If hypernatremia persists, you can increase the renal sodium by furosemide. بس مشكلة الفوروزمايد as we told before, it will increase the water loss more than the sodium, so it may induce more hypernatremia. So you should, if hypernatremia is worsening, the urine loss should be partially replaced with fluid that is hypotonic to urine. لأن هو الفلوزمايد causing about 80 milli equivalent per liter اللي هو الصوديوم loss will be about 80 milli equivalent per liter. يعني كل لتر ووتر هيبقى فيه 80 milli equivalent صوديوم في اليورين. كل لتر ووتر هيبقى فيه 80 milli equivalent صوديوم. ولذلك احنا لازم نعوض we should replace this water by less hypotonic fluid. يعني احنا لو ادينا the same hypotonicity of urine احنا كده عملناش حاجة. يعني we will not correct anything. The furosemide will cause hypotonic fluid loss and we are giving hypotonic fluid, so the net result is 0. So we are giving furosemide. This furosemide will cause sodium loss with water loss, but water more than sodium, and we are giving hypotonic saline, usually quarter saline, because half normal saline containing 77 milli equivalent per liter, which is approximately equal to the amount of sodium which is lost during furosemide use. So we are giving usually quarter or D5 water to replace urine output which is induced by furosemide. Then we will discuss this case, which is very important actually, and will help you to understand clearly what we are discussed in this lecture. Okay, 70-year-old male, again we will tell this case. 70-year-old male patient, a case of COPD, transferred from other hospital with fever, SOB 5 days ago, and altered mental status. he had an episode of seizure 1 day ago. He was being managed on the lines of acute exacerbation COPD with carbammonal and pneumonia, received antibiotics and diuretic therapy in previous hospital. On evaluation, his laboratory values showed hemoglobin 13, sodium 164, potassium 3, urea 146, serum creatinine 1 milligram per deciliter, and blood glucose 400. Case discussion. First of all, the etiology of hypernatremia in this case is multifactorial. If you concentrate on this case, there is many causes of hypernatremia. First, insensible water loss from sepsis, fever, and respiratory. Patient is tachypneic, patient has fever. All of this causing insensible water loss. Then renal loss because he received diuretic. Then he has glucosuria and osmotic diuresis. Then because of hyperglycemia. Then patient also has failure to thrive. As we told, the patient should have both hypotonic fluid loss with failure to thrive or loss of thirst. Due to advanced age, patient is old age and has chronic illness. Then the patient has multifactorial. Then you should send urine osmolality, and urine sodium to clarify the main contributing factor. Urine osmolality and urine sodium will indicate or will clarify what is the main cause of hypernatremia here. Then the patient is symptomatic, has symptomatic hypernatremia because he has severe symptoms in form of altered mental status and seizures. How to manage this patient? First, you should stop diuretics and start treatment of sepsis, treat the cause. You should start antibiotic here and send all cultures and septic workup. Then you should replace water deficit. As we mentioned, first calculate correct serum sodium. Here, what is the sodium? It is 164. What is the glucose? 400. So there is 300 more in the glucose. 300 will induce drop of sodium 6, yes. So this 6 should be added to 164. So the sodium, correct sodium will be 170. Then calculate water deficit. Here the patient is old age, so the total body water is half or 50% of his weight. If you consider his weight is 70, I didn't mention the case, but consider the patient weight is 70. So 70 divided 2, it is 35. So the total body water in this patient is 35. Multiplied the serum sodium, which is 170, divided 140, minus 1. If you calculate it, you will find it is 7.5 liter. So the water deficit here is 7.5 liter. Then what is the amount of replacement fluid? If you replace by D5 water, you should give this 7.5 to correct the sodium from 170 to 140. Now this replacement will correct the sodium from 170 to 140, 7.5. Or you should give about 13.5 of half normal saline to correct sodium from 140 to 170. How you know this 13.5? As we told, we will multiply 7.5, which is which is water deficit. You should multiply it to 140 divided the amount of sodium in half normal saline, which is 77. If you calculate it, it will be 13.5 of half normal saline. Type. You will give this 7.5. What is the amount? What is the duration? You should give this amount of fluid. What is the rate of replacement? Simply, as we told, if we are using half normal saline, this 13.5 liter will decrease the sodium from 170 to 140. So it will decrease the sodium about 30 millimole of sodium. And our target to decrease 10 millimole in the first 24 hours. Okay. So again, if we are using the half normal saline, as we calculate, we will need 13.5 to decrease sodium from 170 to 140. So we need this 13.5 to decrease about 30 millimole of sodium, and our target to decrease only 10 millimole in the first 24 hours. So زي calculation الطرفين في الوسطين. So we'll how to know this amount of fluid. You should multiply 10 by 13.5 divided 30. It will give 4.5 liter. This 4.5 liter will decrease 10 millimole of sodium. Okay. As we mentioned, in this case, the patient is symptomatic, have severe symptoms, altered mental status, and seizure. So, as per new guidelines, you should decrease the sodium in the first hour by 5 millimole per liter. 5 millimole per liter, this 4.5 will decrease 10. 5 millimole per liter, it's about half of this 5.5, about 2 liter. And you should give about 2 liter in the first hour to decrease the sodium by 5 millimole per liter. Then the rest of amount, which is about 3 liter, you should give over the rest of the first 24 hours. If you calculate it, 3000 ml over 23 hours, it will be about 130 ml per hour. I think it's clear. Okay. If a patient is asymptomatic, as an hint, so you shouldn't give this bolus of 2 liter in the first hour. You should decrease sodium gradually over the 24 hours, for the first 24 hours. So you will give this 4.5 over the 24 hours. so you will give about 185 ml per hour. ان في كذا كالكوليتورز كابليكيشنز او على النت بتسهل المعادلات دي كلها طبعا، وبتحسب لك دايركتلي الووتر ديفيسيت في الهايبرناتريميا و even الريت اوف فلويد يو نيد يعني. فور اكزامبل ام دي بلس كالكوليتور كان كالكوليت فري ووتر ديفيسيت. طيب قلنا ان هو ميل على السيم كيس. لو elderly patient على الكيس بتاعتنا كنا خدناها الويت بتاعه 70 زي ما قلنا، صوديوم 170 اوكي، او حسب لك الفري ووتر ديفيسيت 7.5 دايركتلي. تمام. طيب دي طبعا اقدر كالكوليتور تحسب الريت اوف فلويد، بتختار الفلويد اللي انت عايزه بيقول لك الريت على طول. ده طبعا ميل بيشنت elderly again، الويت 70 صوديوم 170. بتختار الفلويد طبعا انت عايز كوريكت هاف نورمال سلاين فور اكزامبل. طبعا الريت هو عمله لك هنا 0.5 مل مول بر لتر بر اور، حسب لك 194 مل بر اور. تمام. فالمعادلات دي طبعا بتسهل الموضوع جدا يعني. And thank you so much. I hope it is helpful for everyone and thank you.